Good morning and welcome to Global Healthcast 23, brought to you by Global Health Press. I am here today with Melvin Sanicas and my name is Joe Schmitt. Good morning, Melvin.
Good morning, Professor Schmidt, and good afternoon or good evening to the rest of the Global Healthcast viewers, wherever you are watching this Global Healthcast.
This is the last Global Healthcast for 2022, and this is what we're going to present. We will give you, as always, our COVID-19 update. We will talk about senior waves, myocarditis, factors that predict post-acute COVID-19, harm reduction against COVID, how SARS-CoV-2 uses host defenses to attack the human body, the mRNA platform for universal influenza vaccine, and humans infect their pets with SARS-CoV-2. Melvin, you are the beginner today with our update on the COVID pandemic situation. Where are we?
Yes, so for those of you who have been following us for the past 22 episodes, you already know that we always start with a quick global COVID epi update, and we get this from the WHO COVID situation report, which you can download and have more information if you want to. This is not real time and this is a week late, but as you can see here, this is a global picture of COVID. The number of new weekly cases remains stable, increased a bit, but stable as compared to the previous week. And the number of new weekly deaths increased by over 10% as compared to the previous week, with over 9,700 new deaths reported. But then again, this is looking at the global picture, right? In the next slide, you will see really how the number of cases change in specific countries. So in the countries with a red color, that means that the cases are increasing. The ones in blue, it means that the cases are decreasing, and the ones in yellow means that there is no or very limited change. And as you can see here, there are countries that really increase their cases, right? And at the country level, the highest number of new weekly cases were reported from Japan, the US, South Korea, France, and Brazil. And not in the top five, but you can see that there are other countries as well in Latin America, like Colombia and Argentina, and in Africa, there's Libya, for example, that's experiencing an increased number of COVID cases.
Interesting. And how does this relate to deaths?
On the next slide, you will see deaths. Here you will see that the highest number of new weekly deaths were reported from the US, which makes sense because the cases are increasing there as well, right? Also Japan, Brazil, France. So basically all of those five countries I mentioned that are top five in the number of new weekly cases, they are also the same countries that have reported the highest number of weekly deaths. Well, except Italy. Italy is number five in terms of deaths, but they are not in the top five in terms of weekly cases.
Interesting. So, speaking a little bit about the future, this is the end of the year review. Any idea how deaths and cases will develop next year?
Well, depends on several things. One, it depends on the vaccination coverage of the country and the booster coverage, especially of the older adults, because as we know, it's still 95% or so of people who are being hospitalized are still the high risk. So it really depends on these population. And secondly, depends on the variants that are going to be appearing next year, because that will play a major role in whether there will be outbreaks or not. And thirdly, also related to variants, but like how often are they going to be appearing and how different are they going to be compared to the previous ones or the ones that we've included in the vaccines. And thirdly, I would say the behavior. We always forget to say the behavior of people, right? Because we always blame the virus, that the virus is infecting us, but really the virus is not able to really go to other people's houses and infect them, right? It's people who are transmitting the virus to other people. And so there are many factors, but I would assume that there will be outbreaks, maybe not as big as 2020 and 2021, but there will be outbreaks here and there occurring.
Very interesting. I have one thought here, and you showed last time how the infants born in 1 year, they are naive to the virus. And now they are exposed again next year, and they will be infected, probably very mild, because it's usually a mild disease. But similar to pediatrics, we have a population of people who get older and who come down with all types of underlying diseases like cancer, rheumatoid arthritis, new therapies that weaken your immune system. So like newborn infants that are at high risk for influenza and other RSV infections, that's what we discussed, there is a population of fragile and immunosuppressed who grow every year, and they are those who will die in the next season. Is that a scenario that would apply?
Well, this is happening as well in other viruses, right? Like influenza or RSV that you've mentioned. So I think it's not impossible that these things can happen.
Yeah. You have another set of data here, and this is daily new hospital admissions by age. What is the
Yes,
point you want to show here?
this is from the New York Times, and I picked this up because this is really interesting. So in the US, 95% of people age 65 had 2 shots of an mRNA vaccine, and only 35%, so less than half of that, have had a recent booster. And that might explain the US senior wave of COVID hospitalizations that have been happening this past summer, autumn, and now that's happening in the US. There is a BA.5 wave, and this wave might actually soon surpass the Delta wave. And it's really interesting because if you look at this image, you will notice that this is really affecting those 60 and above. And the people who are younger than that are practically not really affected in terms of hospital admissions here.
Yeah. So the case numbers are really small here. As it is winter, cases go up a little bit, but this is exponential, right? This is
Yeah.
really going up this way.
Yep.
This
And
may be an
it's
artifact.
a bit worrying because if you look at the Delta wave in August of 2022, you will see that the size is almost the same. Of course, the Delta wave is higher, but it's approaching that at the moment.
Very interesting. Yeah. Very nice set of data. So keep us posted on this one and on the epidemics and the details of the epidemics, and the important messages, particularly if you're above 60 and have underlying diseases, get your boosters, right?
Get a boost. Yeah, get a booster. Yeah.
Yeah. So this is now on myocarditis. What is
Yes.
the message here?
The goal of the study was really to compare the prognosis of myocarditis with viral infection versus post-vaccination myocarditis over the next 180 days. So a total of 866 patients were included for analysis, and they were basically followed up. And the study found a significantly lower rate of mortality among individuals with myocarditis after vaccination compared with those with viral infection-related myocarditis. And if you look at the 3 columns, right? So the first column will explain to you the study and what they've seen. For example, they've seen lower proportion of male patients, more prevalent cardiovascular medication use. The next column, you will see how myocarditis was identified in these patients. And then the last one, which for me is the most important, is really looking at the prognosis of myocarditis from the infection itself and myocarditis from the vaccine. And if you look at the heart failure, for example, dilated cardiomyopathy, mortality, it's a huge difference. And if you look at the graph below, you will also see a huge difference in terms of incidence of negative outcomes, basically. So uh, picture paints a thousand words, right? And this one is pretty clear.
I like this very much. And you may remember our GHC special on adverse events. And whenever it comes to risks, you should always look at risks and benefits, right?
Mm.
And here, what you see is there is a risk with vaccination for myocarditis, but the risk of viral infection and myocarditis from viral infection is this is logfold different, right? This is several fold higher complications with a viral disease versus the vaccine
Yep.
caused disease. Very, very interesting and a very nice summary from the American College of Cardiology, I guess. Very
Yes.
interesting. Yeah. Melvin, you have another one on post-COVID now.
Yes. So this is talking about the post-acute sequelae of COVID, or the PASC, and this is basically what we call long COVID as well, right? And for those who are watching who are not really familiar with this, some people who have been infected with SARS-CoV-2 can experience long-term effects from their infection, and this is known as post-COVID condition or long COVID or PASC. And in this study, really what they found out was that there are four different factors, or four risk factors that can anticipate those who will have long COVID after infection. And these four are: number one, type 2 diabetes; number two, SARS-CoV-2 RNA-nemia. So basically, a lot of RNAs of SARS-CoV-2 in your body. The third one is Epstein-Barr virus viremia. And the fourth one is specific autoantibodies. And this was done by researchers from the Institute for Systems Biology and the Fred Hutchinson Cancer Center in Seattle.
Interesting. So PAS, this is a new term that I learned from you. The question is, what else, despite fatigue, myalgia, not feeling well, what else is included in PASC? Are there other outcomes as well?
Well,
Other phenotypes?
the most common ones are the ones that you mentioned: fatigue, symptoms getting worse after physical or mental effort. So it's also known as the post-exertional malaise. And then you have difficulty of breathing. Some people are complaining that they have chest pains. Some others have what you call the brain fog, or basically difficulty in thinking or concentrating. So it's a lot of different symptoms that are considered to be part of this PASC or long COVID.
Yeah. Very nice. So from PASC, we know the cause. It is the COVID infection. We don't know the pathogenesis, but we know some phenotypes, right? We know some
Mhm.
complaints, but it's very unspecific at this point. So it's difficult to make the diagnosis because many people have had the COVID infections now. And the question is this something else? Do they have a psychiatric disorder? Do they have whatever type of other disease that causes their symptoms? So this is very interesting, and I guess it's a diagnosis of exclusion, right? You have to exclude
Mhm.
everything else, right?
Yep.
Very interesting. And now the highlight for me, the highlight of this global healthcast today. This is how to prevent COVID. I think this is very interesting. Thanks for bringing this, and can you explain to the audience?
Yeah, so I mean, early in the pandemic, people started talking about the Swiss cheese model, right? And the reason why we talk about that is because the Swiss cheese has different holes, and if you combine these different slices, you get a layered approach that basically leads to fewer holes, right? And this is the same for COVID-19 prevention. If you look at the table, you will notice that the strongest protection comes from getting vaccinated and wearing a well-fitted mask properly. But you also protect yourself by distancing, avoiding crowds, washing your hands, and many others. And each of these are very important ways to reduce your risk of getting COVID. but they become really effective when you combine them. And what we want to emphasize is COVID prevention or reduction of your risk is really risk reduction by adding many or ideally all of these different strategies. And because we know that none of these are 100% effective, it's better to really add them up to
Yeah.
reduce your risk.
I have two comments. The first is very interesting point 6, eye protection. I know from influenza that frequently infection occurs through your hands and you put them onto your eyes, and this is a way of infection, right, for influenza.
Yeah.
So this may be the same here. And the second remark is, even if you combine them all, right? If you wash your hands every hour and I don't know, you do this really very meticulously, you still may come down with COVID. So it doesn't add up, right?
Yeah.
You cannot say 95% and 96% and I'm 200% protected, right? This is not the way it works.
Yeah. Yeah, of course.
Yeah. Very good. Antiviral treatment plays a little role today. I don't know why, but few people, if anybody, is using any of the medications once they are infected. Paxlovid as an example. Um, I guess there may be new developments in the future, and that may be something for next year to come. Any thoughts on this?
Well, in general, antivirals are really trickier as compared to antibacterials, right? Because you are trying to eliminate or kill something that's usually it's in your cell, and you're trying to do something about it, which sometimes might also damage your cells. So when you create antivirals, the balance is really trying to create something that destroys a pathogen but also does not destroy yourself. So this is the issue with antivirals versus antibacterial, right?
Yeah, the antivirals have to go into the cell and stop the virus from replicating, right? This
Yep.
is, yeah, yeah. Anyway, let's see what happens next year. Melvin, I brought you a little bit on theory of how COVID infects the human body. And this group of authors came up with a model in vitro. They use basic respiratory tract cells in a fluid layer. And the cells that usually exist in the respiratory tract, the relevant cells, are goblet cells producing mucus. There are these ciliated cells, and there are basal cells. And the ciliated cells, they have these structures here on top that you can see here, and they throw out the mucus. So if you are infected, the virus or the bacterium is thrown out of your body by the waves of these cilia. They have a unique direction and they try to expel invaders. That is the theory. This is how that usually works with intruding pathogens. Now here you see ciliated cells very nicely, how they're doing their job. They're waving around, right? And after SARS-CoV-2 infection, you see here, this looks totally different. The cilia are destroyed, and this is a totally different structure now. So here is what the authors found using this model. The SARS-CoV-2 attaches to the cilia. It attaches via the ACE2 receptor, and then using the cilia, it is brought into the human cell. Next is the virus replicates within 24 hours after infection in the cell, and then it uses the microvilli to go up and be again on the surface of the cell. These microvilli, they enlarge and they really have huge amounts of virus now. And in the end, the ciliated cells, they throw the virus out of the body and they disperse the virus, and infect other cells and even other humans. So very nicely, it was shown that the explanation is the virus uses the host defense to infect other cells and other humans by this mechanism where the cilia expel the virus and spread it more that way. Very interesting. And the background is certainly the virus replicates. There are billions of viruses shed from this cell, and then they are brought to other cells and to humans. So this is the way of the pathogenesis. I thought this was very interesting, very simple, I'm not sure, but a nice in vitro model for SARS-CoV-2 infection.
Yeah.
Any thoughts on that, Melvin? Or
I think it's really interesting that this virus is using the host defenses to spread itself. Maybe it's unique for SARS-CoV-2. Maybe we haven't really looked into other viruses this detailed, but it's interesting
yeah.
how it does this. Yeah.
Now for the next, for explaining or for a theory on how SARS may evolve next year and the years and decades to come, I looked at the pandemic, the influenza pandemic. And what we had here, let's say in 1918, there was an influenza pandemic. Everybody on the globe was at risk for influenza with high mortality because nobody had any immunity. Most people survived, but millions died. The last number I heard was 50 million people who died. Many got sick, but most survived. And those who survived after the infection, they had a partial immunity. A year later, 1919, 1920, the virus came back, it returned, and people who were not immune, they were infected and they produced this wave. Immunity builds up in the green line. So each year the virus comes back, but it has an antigen change a little bit so that it can infect more humans again. But immunity builds up with time because everybody has been infected. And then the epidemics get smaller every year until the virus has a major change on the surface. And this major change is called antigenic shift. And then there is a new pandemic. And for influenza, we have seen these pandemics every 10 to 30 years. So it's quite predictable that these pandemics will come. We don't know when. We don't know at what time the virus decides to have a major antigenic shift and to cause a pandemic. And then the story starts again from the beginning. Immunity builds up with time, epidemics become smaller, and at some point there is a pandemic again. So the theory is it may well be this is what we will see with SARS-CoV-2. And one of the questions that remain from there is if and how influenza and coronavirus will interact. If they will combine in their infects, or if the spread of one will stop the spread of the other. And certainly the third factor here is the human being. By wearing masks, by being vaccinated, these big waves would not be necessary. We could mitigate the waves. We probably cannot avoid them, but we can mitigate them, particularly when it comes to dying from one of these respiratory tract infections. Melvin, any thoughts on what will happen with COVID next year and in the next decade?
No, I think it's really interesting because every time someone asks me about that, it's always not very simple to answer the question because you have to look at the question in terms of the host, which is us, the pathogen, which is the SARS-CoV-2, and the environment, right? And it's always an interplay of these three that results into what we will be seeing in the future.
Yeah. Very interesting discussion. I have some hope, and the hope comes from a universal influenza vaccine that has been shown to protect animals. Now, I told you the influenza virus has like 20 HA lineages, and as they change every year, it is sort of unpredictable to make the best vaccine. And what we really would like to have is a vaccine that protects against all influenza viruses. So in the past, that was done with nuclear protein vaccines, matrix vaccines, stalk region vaccines. None of them really worked for various reasons. Now, there is a group of researchers who used mRNA lipid nanoparticle COVID-19 vaccine. And with that vaccine, all 20 representative HA lineages are covered. In animal models, in ferrets and mice, the vaccine was immunogenic, but it also protected animals, including challenge with mismatched strains. So with strains that were not covered by the vaccine in principle, in all detail. This is really nice, and this really gives you a good hope that such a universal influenza vaccine will be able to mitigate the annual waves in the very near future. And I think this is reason to look hopefully into the next years and decades to come. And just to show you some data on the efficacy, animals, mice and ferrets cannot say, I'm sick, right? So what you do is you measure body weight as a surrogate marker for sickness. And you see vaccinated animals here in purple, they lose less weight than unvaccinated animals. And survival is also better in the vaccinated here in the purple line versus the unvaccinated group. Melvin, any thoughts on this slide?
So one thing, I think it's very hopeful that we might have a universal vaccine for flu in the future. The second thing is I am always skeptical when I see animal studies because for many other vaccines in the past, we've seen a very, very good animal study. And then when we move to the humans in clinical trials, they're not as good as what we see in animals. So maybe
Yeah,
just a bit of, tempering of expectations.
yeah. It is, I guess, hope is a good word, and hope may not materialize,
Yep.
right? But so far, so good. Let's see what happens. I have one other point to make here. This is from a great journal that I like very much, Science. And look here, there was 100%, 110% survival. They have this up here, right? So I guess some of the animals got pregnant during the experiment. And in the end, we no longer had 100% animals, but 110%. I'm not sure why they did not cover the 110 here, but I think this is just funny. Anyway, I have one other important information, and this is SARS-CoV-2 transmission from humans to pets. And SARS-CoV-2 came likely from an animal reservoir, maybe bats. The question is, how frequent are animals affected by SARS-CoV-2? And this is now a community-based study from Idaho, United States, where households who had pets and at least one confirmed SARS-CoV-2 infection in a human being. The study team examined 119 dogs, 57 cats who had clinical signs consistent with SARS-CoV-2, which means didn't eat much or had respiratory symptoms, whatever. And they found that 21% of dogs and 39% of cats had clinical signs consistent with disease. And on sampling, they found that 40 and 43% of dogs and cats were seropositive, so they had been infected. The question is whether recently, when they had the symptoms, or that is not quite clear. But in the end, the virus itself was detected by PCR in dogs and also in cats. And the difference between the 5% and the 40% or 43% may be due to delays in sampling. Now, I don't worry too much about the details of the study. I think the main message from this study is pets are potential reservoirs of SARS-CoV-2. And if we see future outbreaks, we have to be aware that such animals may play a role in these outbreaks as well. This is sort of worrisome a little bit. But again, I have a little dog, but I keep the dog usually far away from myself. I found it very interesting that in this study, close human-animal contact was frequently reported, and sharing of beds and bowls had slight harmful effects. Look, I never share my bed and my bowl, particularly my bowl with a dog. I wouldn't even think of doing this. I mean, I think this is hard to believe. Do you have a dog? Do you share bowls with your dog?
I mean, I don't have a dog, but I have seen people who have shared bowls with their dogs. So,
Really?
yes.
So if I'm a guest and they offer me a nice meal, I have to worry that this is the dog's bowl where they prepare the food.
Well, not
Well,
necessarily. There are human plates, right? But
ah,
it's just that sometimes when the dog eats from their plate, they're okay with it. So,
okay. Look, I wouldn't even think of doing this, right? Anyway, the message from the slide is animals may play a role as reservoirs, and it's not only bats, but it may be pets. And be aware of it in the future. Very good. Melvin, I think this brings us to the end of our Global Healthcast 23 today. We showed you in the COVID-19 update that the numbers are stable overall, deaths and cases, but that there is a difference between countries. There is a senior wave of COVID-19 hospitalizations. Old people who have not received their booster vaccines, they have an exponential increase in case numbers in the United States. Melvin nicely showed you that myocarditis from COVID-19 vaccination is much different from viral myocarditis that occurs without vaccination in a natural way. And there is really huge difference, and the benefits of vaccination far outweigh the risk of viral myocarditis. Early factors that predict host COVID-19 were mentioned by Melvin. There were 4 factors that he named. Harm reduction, it's all about reducing your risk so you can get vaccinated. That was the most effective measure. And then there was also masking, hand washing, eye as an entry into the body, ventilation. You remember all the lists that Melvin showed us. I showed you how the viruses uses host defenses to attack the human body. The mRNA platform offers hope for a universal influenza vaccine. And finally, humans infect pets with SARS-CoV-2, and pets may be an animal reservoir for the virus. That's it for today. Thanks for joining us. Merry Christmas, season greetings, and a Happy New Year. Melvin.
Yes, thank you everyone for watching us in the past 22 episodes and now for this 23rd episode. And for the last slide, I think this is just funny. I just wanted to show that the virus from 2020 has evolved, is still evolving, and it will not be going away. It will be with us for the next, I don't know, decades or so, or even more than that. And it will be evolving, and hopefully our vaccines, our therapeutics will be evolving as well as time passes, and it will be part of us.
Thank you, Melvin. Goodbye, everybody, and hope to see you next year.
Thank you. Stay safe. Get boosted.